So very good morning to one and all. At the outset, let me thank Professor Ganguly, Nirja, and the entire organizing team uh, to put up such a brilliant scientific program. I think very, very impressive, very engaging, I think, and we all have had an academic feast from yesterday till today. I also want to highlight the triple connection, which has brought nutrition on the forefront, along with gut microbiome and probiotics. And I think this symposium has given a huge opportunity for different stakeholders to come together. It's the nutritionists, food microbiologists, food technologists, medical practitioners to have a crosstalk. And it's time that, this kind of interdisciplinary engagement should happen for better and applied work to come in future. Just one statement as a nutritionist, I wish to place on record, and whatever I've heard from yesterday, that in a country like India, being the developing country and now likely to be a developed nation, I think we have to vouch for preventive nutrition than curative nutrition. And when we talk of preventive nutrition, somewhere there is a commitment towards the quality of diet in everyday food. And with today's nutrition science emerging, precision nutrition can come in everyday foods. And we can connect that with the outcome in terms of the microbial diversity. And like it is very clearly said that, if we are healthy, we definitely have more of microbial diversity than when we get diseased. So it's better that we prevent ourselves from becoming diseased, and that's the role a nutritionist of this country has to play. So with these words, I think I'm going to invite our first keynote speaker, Professor George Chandy. Yes, sir. Professor is a director, BCMCH, Tiruvalla, Kerala, former director, CMC Vellore, Tamil Nadu, India. He's an internationally renowned medical researcher with special interest in gut microbiome, hepatitis B infection, preventive strategies in acute fatty liver of pregnancy. He's a fellow of Royal College of Physicians, Edinburgh, and many international hospital society. And I think his innovative model is replicated in smaller hospitals, extending its impact on underserved communities. We look forward to your presentation, sir. He's going to be talking on I think, it is. Talking on gut microbiome and the clinical revolution, the widening horizon. Thank you, sir.
I want to especially thank Professor Ganguly for the amazing leadership that he shows in the area of science, and particularly from CMC over 20 years ago, the way he helped us when we took baby steps in the area of antimicrobial stewardship, as well as the appropriate use of antibiotics. Today, I want to thank Professor Ganguly and Dr. Nirja for this very special opportunity to be at this fantastic symposium. To Professor Chandra Bas and Dr. Sri Kumar and Dr. Sabu for the excellent arrangements made. And as we said a little earlier, the fact that we can be here together at such an amazing scientific symposium is such a privilege. I've been given the task of speaking about the gut microbiome and the clinical revolution. Dr. Nirja emphasized that I must bring in, as a practicing clinician, all the aspects that we need to look at. On the 20th of July, 1969, Neil Armstrong, when he landed on the moon, said this: one small step for man, one giant leap for mankind. So, respected chairpersons and ladies and gentlemen, I believe that metagenomics and all the other things that we have talked about is perhaps for the scientist a small step, but for the world, it is going to be a huge, giant leap forward. Eli Meshnikov, the father of probiotics and the Nobel laureate, said this: the majority of diseases begin in the digestive system when good bacteria are no more able to control the bad. This is the corollary in society as well. When the bad controls the good, society becomes sick. Professor Ramakrishna and myself worked at the Christian Medical College, Vellore, where our mentor, Dr. Marthan, used to say that we own the rotten gut. At that time, I didn't quite understand it until the Australian team led by Shane Bourne landed up in Bombay, and he came down with a Bombay belly. And I thank God that we have all these bacteria within. As a practicing gastroenterologist and hepatologist, I've always known that it is the high bacterial load in the gut that leads my patients to trouble, especially when they have decompensated cirrhosis. And I knew that the ammonia bypasses the liver because of the portosystemic shunting and affects the brain. In my practice, 60% of patients have gas, and again, the small intestinal bacterial overgrowth has been one of the major problems, and I've been using VSL-3 quite a bit. And the wonder drug is rifaximin, which is a non-systemic antimicrobial agent, believed to be a gut cleanser. And unlike other antibiotics, rifaximin increases the alpha and beta diversity and is a eubiotic, as shown in this graph, which was exemplified in the RIFSIS trial. So coming to looking at microbiota in gastroenterology, what are the well-established systems that we have? We know about the enteric infections. We know that H. pylori causes ulcer. We know about Clostridium difficile and the antibiotic-associated diarrhea. We also know about the biliary and pancreatic sepsis. Roles postulated for microbiota in gastroenterology include diverticulitis, inflammatory bowel disease, both ulcerative colitis and Crohn's disease, as well as celiac disease and CA colon. What about other diseases and microbiota? A whole lot of diseases we've been talking about yesterday and today: Parkinson's, Alzheimer's, and neurology, depression and anxiety, as we heard from our Japanese colleagues, cancers, and autoimmune disorders. So the butterflies that we felt in the stomach that we always talk about, or the gut feeling, why is it that we talk about the gut feeling and not about the brain feeling or the heart feeling? And today we are proud to say as gastroenterologists that the gut is our second brain. So we knew all along about the gut-brain axis. So when a patient comes to us who are tense and had problems, we know that there is a connect. But today we know much more about the 3D axis. So I just want to, it's a busy slide, but I just want to highlight this: the microbiota gut-brain axis, the endocrine axis, microbiota gut-heart axis, with the kidney, the whole immune process, the liver, and the lung. Over the urbanization, civilization timelines, it is interesting to note that the scientific milestones followed this. So from our natural habitat, we built our environment, while our gut microbiome also evolved. So today, we talk about the built environment microbiome. And we know that the microbial communities, along with the metabolites, result in a whole lot of chronic diseases, inflammatory diseases, bronchial asthma, whole lot of psychiatric stress-related conditions. And we also know that over a period of time, as infections dropped, the chronic diseases, the immune disorders tended to increase. So I'm grateful to friends in AIIMS Bhubaneswar, in CMC Vellore, and my own team at the Central Research Laboratory in Tiruvalla for their increasing interest in this area. So how do we look at the role of microbiota in clinical disease dynamics? This schematic representation by Vijay et al. In the European Journal of Clinical Nutrition, where it spoke about the role of gut microbiome in chronic diseases. It's a busy slide, but it shows you how the gut microbiome, the gut microbial diversity, and the gut-derived metabolites, with all the ones that we know leading to a host of diseases, or we think that there is a definite relationship with these diseases. My area of interest is the liver and changes in the gut microbiota. The dysbiosis with systemic inflammation is involved with a host of diseases, certainly the chronic hepatitis, alcoholic liver disease, and we had a beautiful presentation yesterday, liver cirrhosis and hepatocellular carcinoma. The prevalence of fatty liver, as was mentioned yesterday, is only increased 30% across the country, 50% in South India. And our aim, our hope, is there some way we can prevent progression? So when a patient comes to me with fatty liver, we grade them grade 2, grade 3, and all that. And then I try and explain to them what fat does to the liver. When there is an injury, the body tries to respond, and there is cicatrization, there is fibrosis. How do we reverse this process? And we don't have any drugs for it. We now have called it metabolic dysfunction-associated fatty liver disease, but we are looking for help in this area. In non-alcoholic steatohepatitis, we have a buildup of liver fat, and we know that the Firmicutes bacteroides ratio, there is a positive correlation with steatosis and fibrosis. When bile acids are essential for fat solubilization, in the presence of dysbiosis, bile acids are preserved. But that leads to increased permeability of the gut microbiota and increased microbial growth. And in the presence of oxidative stress, the pathogens-associated molecular patterns, the PAMs, there is further inflammation and there is liver disease progression. All this is proven data. So when I look at the liver and the microbiota, I find that when there is short-chain fatty acids, acetate, propionate, and butyrate, that can prevent liver progression. Can we go on to precision medicine, personalized medicine, make that happen? How can we prevent the gut microbiome-derived metabolites, mainly the TMAO, from worsening the situation with NASH, fibrosis, onto cirrhosis? So our friends in All India Institute of Medical Sciences, Bhubaneswar, did this study looking at patients with lean NAFLD and obese NAFLD, and they found that there was a relative abundance of certain organisms in each category as depicted in these plots. This is unpublished data, but they are working on this, looking at the microbiome diversity, clinical features in NAFLD to try and see whether we can tweak the gut microbiome to help in this difficult situation. There are a whole lot of other studies with probiotics in NAFLD, which we need to look at. I want to look at the heart with you. We had a little presentation earlier from Assam. The trimethylamine leads to trimethylamine N oxide, resulting in increased blood pressure, cytotoxic effects on the cardiomyocytes. And there is a suggestion that TMAO in blood can be used as a cardiovascular risk assessment. So there was a study done by Wang et al., published in Nature many years ago, 10 years ago, where they looked at 1,800 stable patients. All of them were patients for elective coronary angiogram. And the TMAO levels were measured along with cardiovascular disease, plaque size, and they found that the TMAO levels had a 2.5-fold increased risk of a major adverse cardiovascular event. This was independent of the traditional cardiac risk factors. So at a time today, when we hear about a lot of sudden deaths in young people. I wonder whether this study that was done can be replicated to try and see, because we don't have any markers. We have tropi when the patient has come with a heart attack. But when a patient comes to you, how do you assess the cardiovascular risk? COVID-19 taught us a lot. At that time, we didn't know very much, but we knew that there was a tremendous immune response. We also knew that the cytokine storm led to lung injury. A lot of them were admitted. So at that time, several studies came up, which are interesting data for us to follow up. Fecal microbiota transplant in rats resulted in a decreased expression of inflammatory factors, decreased acute pulmonary injury, and reduced risk in COVID-19 progression. So when you look at germ-free mice, you find very poor immune response. So also with malnutrition, with microbial dysbiosis, there is progression of age-related respiratory diseases as against eubiosis. You restore eubiosis of the intestinal microbial community. There's enough evidence to show that you age in a healthy way. Whole lot of other lung conditions we need to look at to prevent progression of asthma and lung inflammation in chronic obstructive pulmonary disease. Two very interesting factors for the practicing gynecologists. The gut microbiota, the diversity and function, plays a very important role in gestational balance, because with decreased bacterial diversity, there is a preponderance to developing gestational diabetes. And my wife is a gynecologist, is very excited about this. And the possibility of preeclampsia, again, happens when there is decreased by bacterial diversity. So could this be an early marker for gestational diabetes and preeclampsia? Endometriosis, the gynecologist struggles with chronic pain and infertility. Gut microbiota have favorable effects on clinical, immune, and physiological parameters, and patients benefit from treatment with probiotics containing Saccharomyces boulardii. Some of my nephrology colleagues, I've seen them using probiotics left, right, and center. So I was suggesting that this team, we need to discuss something and find answers for this. Are they doing the right thing? I do not know, but they know that in stage 5 chronic kidney disease, there's increased Neisseria, Lactinoclostridium, Bifidobacterium, and they know that that worsens the kidney symptoms. And so they're using probiotics quite a lot. Precision medicine and personalized medicine is certainly the answer. Looking at metabolic disorders, we know that dysbiosis leads to poor regulation of fat storage, obesity, metabolic disorders. So fat excess and high sugar intake leads to colonization of enterobacteria, production of genotoxin colibactin, and the pro-tumorigenic activity. And so we have this new metabolo-infectious triad of microbiota dysbiosis, colonization of enterobacteria, and metabolic diseases. We talked a little bit about cancer. So gut microbiota end products affect intestinal coverage, encourages carcinogenesis. And we know that Helicobacter pylori causes cancer of the stomach. We know that genotoxic colibactin producing E. coli, the COP-EC, is involved most probably with colorectal cancer. Increased bacteroides in carcinoma prostate, and in CA breast, in the breast tissue, we find increased bacillus and decreased lactobacillus. The gut microbiome helps definitely in reducing the risk through anti-carcinogenic metabolites and short-chain fatty acids, while there are a host of other metabolites that increases the risk of cancer disease. The gut-brain axis is an area of great study. There is the proteopathy. There is this term called mapranosis, microbiota-associated proteopathy and neuroinflammation. Inflammaging, which is the prion hypothesis of neurogenerative disorders. So my colleagues looked at patients with Parkinson's disease, and in their study, they found that there was a significant decrease in Lactobacillus ruminus. In the 15 patients they studied with Parkinson's disease, they had taken their spouses, 15 spouses as their controls and normal controls as well. Significant reduction in the presence of Lactobacillus ruminus in these patients. We need to study this much more. Immunological problems, rheumatoid arthritis. It is known that there's an increased abundance of Prevotella copri and a decreased abundance of Faecalibacterium. So we definitely know that this gut microbiota dysbiosis and chronic inflammation is bidirectional. Amit Datta et al. In a study in CMC did the characterization of Crohn's disease patients, as you can see in this taxonomy bar and heat tree. And they found that in active Crohn's, there was lowered diversity, while healthy patients as well as patients with Crohn's, with stable Crohn's, had much better diversity. As seen in this heat map, the abundance of patients with acute active CD as against compared with stable and healthy patients is very evident. So again, my gastroenterology colleagues are using Bifidobacterium probiotic a lot. Is that the right way or not? It is for the scientific community to tell us. The salivary microbiome it's been shown that the microbiota and circadian oscillations and the changes that occurs due to age, coffee, tea consumption, and the microorganisms could be associated with tumorigenesis. And there are lots of correlative studies with the 16S rRNA sequencing reiterating these findings. So the periodontal bacteria, a whole lot of them, can be associated with carcinogenesis. So there are three mechanisms that have been postulated for cancer by oral microbiota: bacterial stimulation leading to chronic inflammation, the influence of cell proliferation, and the production of carcinogens. The skin-gut axis, a whole lot of studies on this, leading dysbiosis associated with psoriasis, skin cancer, and the like. We had a beautiful talk by Dr. Adra Bhatt on pharmacomicrobiomics. So I wondered, when she made that presentation, why is it that we clinicians never asked ourselves, when we give the same drug to two patients, the response is very different. Very, very exciting area. Whole lot of things that we need to do. Is it the microbiome that is doing all this? Very exciting times ahead for us. So to summarize, the microbiome gut organ axis is a huge, big area we need to try and connect this. And again, precision medicine will be the answer. So the way forward towards a clinical revolution would be to predict, to analyze, but at the same time, to intervene. How do you predict? There are 4 stages. The stage 1 is a compositional and functional characterization. Stage 2 is data-driven hypothesis generation. Stage 3 is experimental validation of the hypothesis. And stage 4 is the development, therapeutic development, and clinical research. This is what we've got to work towards. And as we predict, you have 2 approaches, the bottom-up approach or the top-down approach. And in doing that, you have the DNA-based approaches, the metagenomics. You have the RNA-based approaches, which are the metatranscriptomics, protein-based approaches, which is metaproteomics, and the metabolite-based approaches, the metabolomics. So you can choose to do the bottom-up approach or the top-down approach. Could start with the metagenomics, or with, and I would prefer starting with the metabolomics to get us answers. And to intervene, we have the prebiotics, the probiotics, the symbiotics, the combination of synergistic prebiotics and probiotics, and the postbiotics, which are metabolized produced by the beneficial bacteria to support health. In this study done by the AIIMS Bhubaneswar group, Balamurugan et al. Had HIV patients on antiretroviral therapy, on appropriate therapy, and he fed them probiotic chapati. And he found that it decreased the viral load and improved the CD4 counts. This is unpublished data which he's working on. Several studies on probiotics in GI disorders, probiotics in cancer, and probiotics in metabolic disorders, which we need to look at in great detail. And we need to manipulate the gut microbiome for better health with probiotics, with engineered microbiome, with the fecal transplant, which we're going to hear about, and a whole lot of other strategies with therapeutic options. So to conclude, we have something very exciting. And I said, it's as good as landing on the moon, because we now have characterized quite a bit. We need to do much more. We know a lot about the composition. We need to learn a little more. We need to look at the functions clearly and the signatures, as Professor Ganguly said, and intervene with dietary modifications, prebiotics, probiotics, postbiotics, the transplant, and the bioengineering. So this clinical revolution, I think, is at a phase of takeoff. And we have huge widening horizons ahead of us. And that's why we are here. Thank you, Professor Ganguly, Nija. Thank you so much for this opportunity. Thank you for your patient listening.
Thank you, Professor Chandy. I really liked what you said. Gut is the second brain. And you talked about the gut-heart axis. You know, on the lighter side, we always knew they used to tell women that the way to a man's heart is through his stomach. But you found scientific reason now here. Thank you so much.